Thank you, Amal sir. And after an excellent talk by Pilla sir, I hope my microbiota is happy with me today to give me a peace and less anxious mind for this presentation because I fed it with put and cuddle in the morning. Okay. Thank you, Amal sir. Now, this is Dr. Charles' daughter. He's the father of interventional radiology. And he once said, and I quote him, that if you're not going to do something just because it has never been done in the past, then think again. And he's the one who first did the peripheral angioplasty back in the year 1964. And that was for a lady who had PVOD, peripheral vascular occlusive disease, and she rescued her from being amputated. Now, the term IR, as Amal sir had already said, is coined in the year 1974 with the philosophy that radiologists can not only diagnose, but that they can also treat diseases. Now, in this presentation, I'll take you through various spectrum of what IR does, starting from the invasive angiograms to biopsies, aspirations, ablations, embolization procedures, and then finally the transplant procedures. This is an iotogram. Actually, this is a spotter for our residents, which shows abnormal sciatic artery. Normally, the femoral artery comes from the external iliac artery. Here, you can see that it is going away from the femoral head. So, these are the persistent sciatic artery. These patients are prone to develop ischemia if they sit for a long time because the sciatic artery goes underneath the ischial tuberosity and they can eventually develop thrombosis or aneurysms at that site. Now, to gain access into a vessel, we use something called Seldinger technique, wherein we give local to the puncture site, which usually is either femoral artery or the radial artery. Very rarely we use axillary or brachial approach. We puncture the needle with the hollow needle. When the blood comes out, we take in a wire through that needle and then secure that wire with a sheath, and we have access now into the vessel. Now, what are the various venous interventions we do? We do interventions for varicose veins, for varicose seals, we do embolizations in them, for pelvic congestion syndromes in females, and then various samplings for various endocrinopathies. Here again, we might use our transjugular axis if you're going from up or transfemoral axis if you're going from down. This looks like an Eiffel Tower. This is actually a lymphangiogram. So these are the pelvic lymphatics. All these white things are pelvic lymphatics. And when is it done? It is done in patients who are suspected to have chyle leak, chylous ascites or chylous effusion. This is an image of an elderly woman who underwent massive radical dissection of the lymph nodes in her retroperitoneum because she had CA ovary with lymph nodal metastasis. And after the surgery, she had severe malnutrition because of protein loss, and that was because of a chylous ascites. So they came to us, they asked us to find out whether she's got a lymph leak because there was high triglycerides in the ascitic fluid. So we went ahead, what we did is that we punctured her lymph node in the groin, and then after puncturing, we inject something called lipiodol. It is a ethiodized oil of poppy seed which is used for embolization. It is also a viscous contrast agent, so that we injected into her lymph node bilaterally, and on the right side it is okay. All these white things are the lymphatic channels in the pelvis. On the left side, within half an hour to 1 hour, when the lymphatic channel in the left iliac, common iliac station opacified, it slowly started reflexing into her drainage catheter. So then we came to know that yes, this is the point of the leak. This is the CT on the left hand side, which shows the lymphatics draining along the common iliac vessels and further up, this is the cisterna chyli, and then along the thoracic duct to reach almost up to the internal jugular vein. So, in such situations, what we do is that we get in to that leaking point with something called a Chiba needle. It's a 22 gauge, very thin needle. And then we go into that leak point and we embolize it. So this image is a CT image after embolization, which shows lipidol concentrated in the point of the leak. And this is really life-saving in these kind of situations. Now, let's see what are the things which we biopsy. Literally, we can biopsy from anywhere except the brain, the spinal cord, and the bowel. This is how our usual biopsy tray looks like. It has a biopsy gun, a coaxial needle, and a local. Now, what we do is that after giving local, we take the coaxial needle. This is a picture which is showing the coaxial getting inside the patient's skin, and under ultrasound guidance, we take the coaxial up to the lesion. And earlier, we used to take the biopsy gun repeatedly across the capsule. But now with the coaxial, we don't have to do that. Once the coaxial is in place, we can take the biopsy n number of times. And suppose this is a lesion, we can take the biopsy, and the biopsy gun is not going to come in contact with the rest of the parenchyma. So there is less chance of tumor seedlings along the tract. Another advantage is that after the biopsy is done, we can embolize this tract with gel form slurry. Suppose the bleeding parameters are not normal and there is a gross ascites, we can still do biopsy by doing something called transjugular biopsy. In this, what we do is that we take jugular axis, we puncture the jugular vein, get a wire across the SVC into the IVC, and then we cannulate the right hepatic vein, and then we take a long biopsy needle around 45 centimeters. We go to the liver, and from the hepatic vein, we puncture the liver parenchyma to take the biopsy. In this case, even if it is bleeding, it is not going to go extravascular. It is going to bleed inside the vessel only. So, literally, there is not going to be any volume loss or blood loss. Renal biopsies are always tricky when compared to the liver biopsies. It is also because all these patients who are sent for renal biopsy may have higher creatinine and platelet dysfunction. So they are more prone for biopsy related bleeding. So what we do is that we follow a path, a Brodel's path, which is said to be a relatively avascular zone, but it is not practically possible in all the cases. And we might result in something like this. This is a patient who had massive hematoma around the kidney. That's the kidney, and this is a massive hematoma around the kidney. So in these patients, then what do we do? Then we'll have to take a CT. We'll have to localize from where it is bleeding, what is the bleeding point. We'll have to look at the anatomy, and then we get into the renal artery via femoral approach. That's the angiogram, which shows active ooze of contrast from the puncture site, and then we finally go there at the leak point and we embolize that with coil. So this is after coil embolization. You can see that extravasation has completely stopped. Now, to avoid all these things, because once the patient bleeds, he might have page kidney, he might be subjected to surgery, that hematoma can get infected, he might go into sepsis. To avoid that, we are using something called glue embolization in high-risk patient, wherein immediately after doing the biopsy, we patch the tract with a glue, and it looks like that. And then in these cases, the bleeding can be avoided. Now, these are the various biopsy procedures which we do. The first on the left-hand side is a CT-guided biopsy from the right adrenal gland. The one on the left, on the right-hand side, is the biopsy from an anterior mediastinal mass, and this is lung biopsy. Lung biopsy we can do up to the lesion of up to 10 millimeter size. Of late now, what we are doing is that when we do lung biopsy, there is a chance of pneumothorax. So what we do is that now we do something called autologous blood patch technique. So we take the patient's blood. After doing the biopsy, we patch that area up to the pleura with patient's own blood to avoid pneumothorax. That's a transpedicular biopsy for a suspected metastatic lesion in D9, D10 vertebral body. We take, under fluoro guidance, we take a transpedicular approach to enter the vertebral body and then take biopsy from that. This is a patient who is suspected to have tuberculosis. She had collections around her psoas. So this is simultaneous needle positioned into both her psoas collection and pus was aspirated. Now, these are minimally invasive procedures, and few patients really they have so much gratitude to us, and especially if you guys, if the physicians are there with IR, like a fist, we can actually push the surgeons away. On a serious note, actually, our procedures they are less painful, they have faster recovery time, and they have low surgical risk when compared to a major surgery. Now, let us see what are the therapeutic interventions which we do. Starting with aspirations and pictal drainages. We do percutaneous nephrostomy for those patients wherein there might be an obstruction to the renal pelvis or to the ureter, or if there is a leak or fistula down there in the ureter or in the bladder. For this, what we do is that we use a posterior and lower approach. We puncture the pelvis and secure the catheter into the obstructed system. Initial catheters were straight catheters and they would not stay there within the cavity and might slip out. So it was Sir Constantine Cobb who designed this famous catheter called pigtail catheter. And that is how a pigtail catheter looks like. And unless specific steps have been taken, these catheters cannot be removed. So this is how it works. There is a stellate inside the pigtail catheter. Once we take out the pigtail catheter, it looks like a pig's tail. That is why pigtail catheter. Coming to PTBD. PTBD can be done under fluoro or under ultrasound guidance. We take in the Chiva needle, puncture the left or the right duct as per the clinical scenario. And this might be done either to drain the bile which is obstructed, or in cases of cholangiocarcinoma, we might opt to stent that duct. Sometimes after the surgery, like hepatocystinostomy, there might be a stricture at the hepatic hilum. So we might intervene to open up that stricture. And lastly, we might do percutaneous cholecystostomy in those patients who are not operable. So I was telling about this pigtail catheter. Now something important which I just want you to know is that, see, this on the top, this is pigtail catheter. It has holes only in the tip. But this is a biliary drainage catheter which has holes both in the tip as well as proximally. So suppose we have a clinical scenario where there is a lesion at the hepatic hilum, that yellow dot there, and we are able to place the catheter proximal to that lesion. We are not able to cross that lesion. In those situations, we will be putting a pigtail catheter. But then, suppose we are able to cross that lesion and go ahead up to the duodenum. In these scenarios, we will keep a biliary catheter. The advantage of biliary catheter is that if we close the tip of the biliary catheter, there is no loss of bile salts and electrolytes. This is how we do PTBD. We puncture the duct under ultrasound or fluoro guidance, take in the wire, and then slowly we put in the pigtail catheter. This is a MRCP image of a young patient with primary sclerosing cholangitis. We can see that the right and the left hepatic ducts are significantly dilated. This is a coronal image. It's not just dilated, it also shows multiple filling defects within. So these filling defects are nothing but calculi, all of these things. So we proceeded with, because she was having recurrent cholangitis, we proceeded with cholangiogram to drain this. But then when we did the cholangiogram, we can also see multiple strictures. So this is the stricture around the common hepatic duct. So we got in and then we put in a pigtail catheter, and after doing so, we decided to plasty that stricture. You can see that there is a balloon there at the point of stricture, and you can see a waist in the balloon, that is the point of stricture, and then we finally dilated and drained her with an internal external catheter, biliary drainage catheter, and a pigtail catheter. This is a fluoro image of yet another patient, a case of carcinoma stomach with obstructed CBD at the hilum, and they were not able to give chemo to him because of much elevated bilirubin. So they wanted us to drain the bile duct. We got in, we drained the bile duct, and we did a palliative stenting. And you can see how the stent struts are compressed around the lesion. Now these are self-expanding metallic stents, and over a period of time, this will eventually expand and drain the bile. This is another PTBT image which shows this is a patient who underwent transplant, and see, after transplant there was a stricture at the hepaticojejunostomy site. So again here we were called, so we went in, we crossed the stricture, that wire is going across the stricture into the jejunum, and after crossing we dilate that. After dilating, we put in a pigtail catheter or a biliary drainage catheter, and this drainage catheter might be kept for 6 months, 1 year, up to 2 years until that stricture heals and gives off. Percutaneous cholecystostomy is done for those patients wherein those who cannot be taken up for surgery because of many comorbidities, and for those patients where after cholecystitis the patient's GB has given off, it is ruptured. So in those scenarios the surgeons cannot intervene because of the adhesions. So temporarily we keep a pigtail across the GB. So that is percutaneous cholecystostomy, and this is how it is done. Initially, we puncture, we give local anesthesia. We take in that black thing, that is a needle going into the GB through the liver. We do it through the liver to avoid spillage of the bile into the peritoneum. And then we take in a small wire. Once the small wire is taken, then we exchange that smaller wire for a bigger wire, that green wire. And over that stiff wire, we take our pigtail catheter, that yellow one. And once the pigtail catheter is in place, we pull out the stillet. When we pull out the stillet, it gets locked and the bile is drained out. Let's see on the various ablation procedures which we do. Ablation may be chemical ablation or it may be thermal ablation. Chemical ablation, we use alcohol, and for thermal ablation we use radiofrequency ablation or microwave ablation. Now RFA and microwaves are much better than alcohol ablation, and alcohol ablation is limited to those areas or those lesions which are less than 1 centimeter, or those where we cannot access the lesions for thermal ablation. The latest on ablations is irreversible electroporation and cryoablation. It is there in India, but it is way costlier than the RFA and microwave, so we commonly resort to RFA or microwave. RFA and microwave, in both of these modalities, there is ultimate coagulative necrosis within the tumor, and that is how the tumor is taken care of. This is a picture which shows the needle across the liver into the lesion. This was hepatocellular carcinoma within the liver, and this is getting ablated. Microwave ablation is actually more stronger and more effective than RFA, because the heat generated in microwave is much more rapid when compared to the RFA. One problem with microwave is that it does not respect boundaries. In RFA, if you use a 3 centimeter needle, it is going to ablate only 3 centimeter. But microwave depends really on the time. If you prolong the time, it will go on ablating more and more area. So the chance of complication is also higher with microwave ablation. Of late, we have also started doing ablation for thyroid. Thyroid ablation is done for benign thyroid nodule. So nodules which are benign, with at least, we have to do at least 2 FNAC with a gap of 1 month to prove that that nodule is benign. So Bethesda 2 nodules, category nodules can only be ablated, and those lesions should be less than around 30 to 40 cc for us to ablate. Now this is a colloid nodule, a large colloid cystic nodule in an elderly lady. She was having compressive symptoms, so she came to us. We did something called alcohol ablation. So we aspirated, this was around 20 ml, we aspirated 20 ml of fluid, and then we injected 10 ml of alcohol into this cavity, and after injection, this is the immediate picture. So 20 ml became 2 ml. So we inject the alcohol, we keep the alcohol for around 10 minutes, and then we aspirate it back. And after 1 month when she came, she was very happy. The cyst had completely disrupted. But at the same time, if it is a multinodular goiter which is more than 50 cc, we would prefer to do something called thyroid artery embolization rather than doing thyroid ablation for these patients. In these cases, we get into the thyroid artery, the superior and the inferior thyroid artery on either side, and we'll just leave one of them so that The parathormone is not getting affected. This is an image which shows ablation of a bony lesion. Most common bone lesion which we ablate is osteoid. Let's get into the various embolotherapies which we do. Now, what is embolization? Embolization is nothing but it's a deliberate occlusion of a vessel of a biliary system or a lymphatic channel for therapeutic purpose. Now, for embolization, we might use different materials. It might be solid or liquids. In solids, we have this, the one on the left hand side is a plug, and the one on the right hand side is a coil, and on the extreme right is PVA particles. There are different kinds of particles, polyvinyl alcohol particles, embospheres, etc., which we use for embolization. Now, which are the different scenarios where we go and do embolization? One, if there is active bleeding from anywhere in the body. Second, for targeted chemotherapy, like in hepatocellular carcinomas or neuroendocrine metastasis in the liver. We also do preoperative embolizations for lesions which are very vascular, like a hemangioma. Now, suppose there is a vertebral body hemangioma with a large paravertebral component which is compressing on the dura. Surgeon might be going to operate so that he has a bloodless field. Before the day before the surgery, we get the patient, we embolize it, we cut off the blood supply so that next day surgeon has a bloodless field. We also do embolization to relieve pain, for example, in osteoarthritis, in adhesive capsulitis, etc. So this is what I was saying. We choose to use liquids, particles, coils, plugs, depending upon what is the site we are going to embolize, what is our desired result, whether we want to embolize it permanently or we want to have only a temporary embolization. This is a case of pulmonary tuberculosis. Patient has distracted right upper lobe with fibrocavitary changes. He had presented to us with hemoptysis. We did a CT angiogram which showed hypertrophied bronchial artery, and then we got into his aorta. We selectively engaged his bronchial artery which showed abnormal blush in the right upper lobe, and then we embolized it with PVA particles. And this is the result after embolization. This is another case wherein there was a large vertebral body hemangioma with significant soft tissue component compressing on the dura. So this patient was sent to us for preoperative embolization. But here, what happened is that when we were doing selective angiogram, we saw an artery ascending from the radiculomedullary branch, ascending up like this and then coming down, this having a hairpin bend. So this is classical of a artery of Adamkiewicz or anterior spinal artery. If we continue to embolize in this situation, we might have infarction of the cord, and if such a thing is there, we might defer embolization after taking him for angiogram. Other scenarios where we do embolization is in CLD. In CLD, if patient is having significant varices and hematemesis, especially the perigastric varices which are decompressing through the renal vein, we get into the IVC, we go selectively into the renal vein, and after going into the renal vein, we go into that shunt from where these collaterals are decompressing. We inflate a balloon and inject sclerostin into those perigastric varices to destroy them off. And this is a CT after embolization which shows good sclerostin cast into those varices. But there is a problem. Initially, when we used to do balloon embolization, these balloon might give off or rupture, and there might be catastrophe of the entire embolizing material reflexing back into the renal vein and further into the IVC. So of late now we are using something called plug. So when we use plug, it is called plug assisted retrograde transvenous occlusion. When we use balloon, it is called balloon occluded retrograde transvenous occlusion. So this is an image wherein we have put a catheter at the shunt, and then we are going to deploy the plug. See, this is how we are deploying the plug. Once the plug is deployed, the shunt will be closed. Now, this is a patient who had significant pelvic pain and pelvic fullness, which was cyclical. So we did a CT, and she had something called pelvic congestion syndrome, where there are lots of abnormally dilated parametrial veins. So in these conditions and also in varicoceles, we can do sclerosant injection into those abnormal vessels and clear them off. This is a CT image which shows a large pseudoaneurysm at the splenic hilum. Now, he was not a surgical candidate because he was in sepsis. And the other option for this to tackle this ticking bomb was to do embolization. But then his celiac artery had significant stenosis. So there is no other way to get into the splenic artery other than the celiac trunk. So what was the option? Then they came to us. So we thought if we can take a transsplenic access. But taking transsplenic access is also dangerous because it can bleed from the spleen. So the only option which we were left with is to take a smallest possible needle. That is the Chiba needle, which is 22 gauge. We took the needle across the spleen, got the needle inside the sac, and we used something called biological glue, which is a combination of thrombin and fibrin. So around 1 ml of thrombin and fibrin was injected into this ticking bomb, and this is the picture prior to the embolization, and that on the right hand side is after the embolization. The complete aneurysm was taken care of with this method. This is yet another similar case. Here also the patient had pancreatitis and there was a pseudoaneurysm. But to embolize that, we were not really seeing a vessel which was reaching up to that aneurysm. So only if we can see a vessel reaching to the sac, can we go into the sac and embolize it. Here, there was no vessel, but the pseudoaneurysm was there. So this again, we thought we'll puncture under ultrasound and do the same thing. But under ultrasound also, it was so small that it was not well seen. So then we did something called contrast enhanced ultrasound. This is the image on the right hand side is a contrast enhanced ultrasound, which shows us the active filling of the aneurysm sac. And with this, we traced that, we tackled that, we punctured that with a needle and embolized with thrombin. So this is prior to embolization and this is post embolization. This is a patient with polytrauma. He had aneurysm in his maxillary sinus, and for this we got into his left internal maxillary artery and embolized that with glue. This is another patient who has a large mass in the upper pole of the right kidney. This was having fat content in CT. So it was an angiomyolipoma. Now angiomyolipoma, if it is small, we can leave, but this was around 8 to 9 centimeters. So in the angiogram, you can see it is almost the size of the kidney, and this we embolized with embospheres, and that is after embolization. It looks as if the upper pole of the right kidney has been taken off. Now, suppose there is a large cholangiocarcinoma. So the surgeon used to do something called ALPS, and this was done so that when they take the right lobe of the liver out, there is significant functional liver residue to take care of the patient once the right lobe has been removed. So they used to partition the right lobe from the left lobe, and they used to ligate the right portal vein. We also have something for this. What we do is that we get into the right portal vein via transhepatic approach and into the hepatic vein via transjugular approach, and we embolize the portal vein. So this is the image which is showing embolization of the right portal vein branches using glue, and after embolizing the right portal vein branches, we have also put a plug in the right hepatic vein. And what do we intend to do? We intend to see hypertrophy of the left lobe and eventual atrophy of the right lobe. So within 2 weeks, there was good hypertrophy, and this patient was taken up for surgery. She is doing well even now. Now, various transarterial chemoembolizations. The advantage of the transarterial chemoembolization versus systemic therapy is that there is 20-fold higher concentration of the embolizing agent within the tumor with this procedure. Apart from that, we also occlude the vascular supply to the tumor, which causes ischemia. So suppose this is HCC and that is a feeding vessel. So we get into the feeding vessel and selectively give the chemotherapeutic drug into the tumor bed. And nowadays we are using something called balloon TACE, wherein there is extra delivery or excellent concentration of the medicine into the tumor bed. This is the image on the left hand side is prior to embolization of a hepatocellular carcinoma. On the right hand side, it is after the embolization. Now, suppose if there is a portal vein thrombus, we might defer to do TACE. In these situations, if there is a segmental portal vein thrombus, we will do something called transarterial radioembolization, wherein we use radioactive particles, which is yttrium-90. It is a bit costly. It comes to around 12 to 13 lakhs. That is because this yttrium-90 is acquired either from Canada or from Australia. So this is how the yttrium beads look like. This is when it is compared with a single strand of the hair. We also do embolization for uterus in cases of uterine fibroids and in cases of focal uterine adenomyosis. So this is the image which shows embolization of the uterine fibroid. There's a angio which shows abnormal blush within the uterus in a case of uterine fibroid. We embolize this with either PVA particles or gel form. After the embolization, these patients may have some post-embolization syndrome, but it is significantly less painful and they have relatively faster recovery when compared to hysterectomies. This is another case of benign prostatic hyperplasia. Those patients who have prostate volume of more than 40 cc or who comes with bleeding or hematuria, we pose them for prostate artery embolization. That's the image showing embolization of the prostatic artery. These are all images showing various pictures of prostatic artery embolization. We also do genicular artery embolization for osteoarthritis of knee. Now the funda here is that whenever there is osteoarthritis, when there is active pain, there is synovial inflammation and synovial hypertrophy. So as in a tumor there is neovascularity, these abnormal synovial hypertrophy also has neovascularity. So that is exactly what we deal. So when we go and embolize those neovessels, the inflammation comes down and further damage is arrested. The pain also comes down. That's a patient, a nulliparous patient, who's around 35-year-old, trying to get conceived, and she came with missing periods. But ultrasound did not show any sac, any gestational sac in her uterine cavity. But her beta HCG was around 28,000. So then we did the ultrasound. When we did the ultrasound of the abdomen, we saw something suspicious in her retroperitoneum adjacent to the aorta. We went ahead with the CT angiogram, and in CT angiogram, we were surprised to see ectopic gestational sac adjacent to the aorta. So they asked us if we could do something, and we went in and injected methotrexate percutaneously, and this is the image after 20 days. The sac has been completely destroyed. We also opt to put in stent in certain situations, and what are they? First, we'll talk about tips, wherein in a patient with CLD, with refractive ascites or bleeding, we puncture the portal vein via the right hepatic vein. So this is the image on the first image shows the catheter in the right hepatic vein, and the second image shows the catheter has been progressed into the portal vein via the liver parenchyma, and the third image shows dilatation of that tract from the hepatic vein to the portal vein. This image shows a pictal catheter, a portogram, which is showing opacification of the portal vein. Then we have stented that segment and created a shunt from the portal vein into the hepatic vein and IVC in case of CLD. And these patients usually become dry in around a week's time. This patient, actually the intensivist had put in a central line, but after putting the central line, the blood was bright red in color and it was pulsatile. So he had taken an X-ray. When the X-ray was taken, the tip of the catheter was somewhere near to the scapula here. So we were called in, we did the ultrasound Doppler, and we had a suspicion that the catheter tip was in subclavian artery. But he was very sure that he has punctured the jugular vein. So we did the CT angiogram, and we did volume rendered images which showed, see, this is the tip of the catheter, this is the tip of the catheter. So he has punctured the jugular vein, the catheter has gone through the jugular vein and it has gone out, pierced the subclavian artery, and through the subclavian artery it has reached the tip lying in the axillary artery. So now what to do? If we take this out, he is going to bleed to death. This is the positive view of the same thing. So we did the angiogram, we got into the aorta, went into the subclavian artery, did a angiogram which showed active leak of contrast from the site of the puncture. So in this situation, we went in and we put in a covered stent. So this, we are placing the covered stent, and this is the image after covered stent is completely healed. There is no leak, everything is absolutely normal. This is another picture wherein there was a aortic aneurysm. So we go in and we put in aortic stent grafts in these situations. This is a patient who had hepatic venous occlusion immediately after the transplant. So the first image shows occluded hepatic vein. We went in transhepatically, we plastered that and we put in a stent. See, you can see some small narrowing in the proximal aspect of the stent. We thought we will follow up. Yes, I just finished off. And so the next day when we called the patient, the stent head was occluded. So now what we do, along with thrombolysis, we have some gadgets like angiojet, where these are mechanical thrombectomy devices wherein they will macerate the thrombus and take it out. So we did that, and finally we placed the stent, and this is the Doppler after 48 hours, which showed complete recanalization of the occluded hepatic vein. I'm going to finish it off now. And we also have something called snare. Now, we do lots of intravascular intervention, so it is possible that when we intervene, all these catheters might break in the vessel. So now what to do if such a thing happens? For that, we have something called snare. It is a device which is used to retrieve foreign body from the intravascular component. This is another picture of a patient for whom central line was being put. The intensivist was so busy putting the wire that finally he discovered that the entire wire has slipped out of his hand. The entire wire was in the jugular vein up to the inferior vena cava. The cardiologist was called, then the vascular surgeon was called. He did not want to open. Then finally we were called. So we went in with our snare. We caught hold of the tip of the J wire, and this is what we did. This is a 5 minutes job for us. We took out the wire and she was rescued. Thank you.